upon Dr. B.G. Dharmanand sir to give a practical demonstration on examining joint tenderness.
We would have loved to demonstrate on a live patient how to examine a joint, or at least tell you how we examine a patient with arthritis, rheumatoid arthritis. If a joint looks like this, it's extremely easy to make a diagnosis. You can see a swelling here, swelling in these joints. The pattern also you recognize, the swelling in the MCP joints, swelling in the PIP joints. The nails are looking okay. If you have seen the wrist also would have been swollen. This pattern is typically rheumatoid. This is an opposite pattern. You see a swelling, bony swelling in the distal interphalangeal joint and some proximal interphalangeal joint, and MCP look reasonably all right. So if somebody comes to you, we would think more of osteoarthritis rather than rheumatoid arthritis. What I am going to do now is to play a nice video made by rheumatologist to train the rheumatologist in clinical trial. This is a fantastic video, very well made. So I will run the video, and after each organ we will stop for a minute or two and discuss anything which you would like to know more.
Today we're going to document the 66-68 tender and swollen joint count. We'll work through this systematically and demonstrate the exact anatomic locations and movements that you should go through to demonstrate whether the joints are tender and or swollen. The tenderness can be demonstrated either through pressure on the joint, and the amount of pressure applied should be enough to blanch the fingernail. It should be applied in one single squeeze and not repeatedly. Swelling should never be taken for granted visually, but the joint must be palpated to see if there truly is that soft, squishy swelling of thickened synovium. We'll start at the top of the joints and work our way down. You should have somebody in the room who is systematically recording the joint results with you. We have 66 joints that we will record for tenderness, 68 for swelling. We do not include the hip joints for swelling because they are deep and cannot be palpated, nor can they be palpated for tenderness, but they can be moved. Okay, I'm going to start the 66-68 joint count now. We begin with the temporomandibular joints, which is right in front of the ear. The finger is placed in front of the ear and over the temporomandibular joint. You can feel the gap there. Have the subject open and close their mouth and ask if there's any tenderness there.
Yes.
Yes. And which side do you feel the tenderness?
Both.
Both sides. So that would be recorded as tenderness in the temporomandibular joints on both sides. There's no swelling felt there. We now go to the sternoclavicular joint. That's at the medial end of the clavicle where it meets the sternum. I put pressure there, blanching my fingernail. Is there any tenderness there? No.
So the principle is to, when you want to look at swelling, swelling will become obvious. Even if it is obvious, sometimes the swelling could be a bony swelling. So gently palpate to look for a feel, boggy feel of synovial swelling and fluid inside. And when the patient is hurting, even on a slight touch, don't press beyond a point. There is no point in hurting them. When you are examining the joint, you should not be hurting. Gently feel the joint. If they say it is painful, then don't press further. But if they don't feel pain, press as hard as required, like just enough to blanch your nail. So that is the maximum pressure you can use. So at that pressure, if the patient doesn't have pain, it is not painful. We can reasonably be sure that this joint is not a painful joint.
Now go to the acromioclavicular joint over at the distal part of the clavicle where you can feel the little indentation, and I'll put pressure over the acromioclavicular joint. Any tenderness?
No.
No tenderness there. Next, we'll move on to the shoulder joint. First of all, we must expose the shoulder joint. Tom, I'll get you to pull that over a little bit for me. The shoulder joint space is easily palpated just in front of the deltoid muscle. If you're not certain, move the joint around and you can find the space very easily. Put pressure there. Is that tender? Because there's no tenderness to palpation, I'm now going to move the shoulder joint to see if it's tender at all. Please tell me if any of these movements give you any discomfort. I'll move it through flexion, extension, external rotation, internal rotation, and abduction. And it looks with a little bit of a wince that we have some tenderness there. So this would be recorded as a tender joint. I do not feel any swelling in the area of the shoulder joint, so it would not be recorded as a swollen joint. The elbow joint can be seen in between the epicondyle and the olecranon bursa. It can also be palpated at that space. Palpate it for tenderness, being careful not to put pressure on the epicondyle, which is also tender at times, but is not the joint space, and being careful not to palpate the olecranon bursa, which may be swollen, but doesn't reflect the joint space. So you're really palpating the gap in between the radial and ulnar head where you can see this depression here. Sometimes it may bulge out at you. If this area is not tender to palpation, then you would test for tenderness by extending the elbow joint and it flexes up. Okay, now we will move on to the wrist.
Here one more point for you to remember. We should know the surface anatomy, particularly for bigger joints. See, generally we assume the shoulder, we'll just press here. Actually the shoulder joint is little proximal. So you should know the surface anatomy of the joints so that you can feel the right areas for pain. And on palpation, if there is no pain, and move the joint within all the ranges. If this is elbow, extend it fully, flex it fully, and if there is no pain, this joint is a pain-free joint. And this is called stress pain. Even if there is very subtle synovitis, full extension and full flexion would hurt. So this joint would be counted as a tender joint. And obviously she has explained where to look for the swelling. And pain in and around the joint is not joint tenderness. So the tenderness at medial epicondyle will not qualify as a tender elbow joint. So that is one point we should be clear about.
To evaluate the wrist, visualize it, palpate the wrist over the radial head, to the side of the radius, and to the side of the ulna, feeling for the thickness of synovial thickening. Is that tender?
The wrist on the right side.
Okay, the wrist is tender, so we would record that as being tender without necessarily putting it through its range of motion. If it was not tender, we would then flex and extend the wrist and then rotate it from side to side to see if we could elicit any additional tenderness. I'm now going to demonstrate the metacarpal phalangeal joints. These joints are palpated individually. Again, they have to be palpated. You can't assume that because they look enlarged that they are swollen. That may simply reflect some subluxation. We're going to palpate from the sides, and if that's not tender, we'll palpate from the top and bottom also. If that's not tender, then we will put the metacarpal phalangeal joint through a range of motion to see if it's tender. At the same time that we're palpating for tenderness, we can assess to see whether that joint is swollen also. I'll demonstrate that on the second metacarpal phalangeal joint. I'll put pressure from the side. Is that tender? It's not tender. So I'll squeeze it from the top and bottom. Is that tender? It's not tender. So now I'll flex it and extend it. Any tenderness there? So that would be recorded as negative for tenderness and swelling. I'll do the same with the third MCP joint. Okay, put it through its range of motion, still non-tender, and there's a little bit of swelling there. I would certainly record that as being swollen. I'm going to palpate the fourth, tender at all, and I'll feel that from the top and the bottom, put it through its range of motion, no tenderness, no swelling. Same with the fifth. Tender, a little bit of tenderness there, and I've detected a little bit of swelling, so technically I don't need to put it through its range of motion. This is a tender and swollen joint. We then do the same with the PIP joints, the thumb IP joint, press for tenderness, Any tenderness there? It's not tender, it's not swollen. I put it through its range of motion. It's not tender. Do the same with the second PIP. Tender, not tender. Bend it up and down, not tender, and it's not swollen. The third PIP, similarly, no tenderness. Put it through its range of motion, still not tender. Fourth, little tender there, so I don't have to put it through its range of motion. Tender, little bit tender there, I don't have to put it through its range of motion. And finally, we check the DIPs, giving them a squeeze. Any tenderness there, no tenderness with motion. Tenderness there, little bit there, I don't have to flex it. Tenderness there, none, we'll just double check it. Tenderness there, no tenderness. Flex it, no tenderness, fine. Now we're ready to move on to the lower extremities. Let me get you to lie back.
Again, a similar pointer, MCP. When I initially joined rheumatology, I thought MCP is somewhere near the knuckle. So this is where the joint moves. So we used to press here. Actually, it is little proximal. So we need to know the surface anatomy to really palpate the joint lane. This is generally how we look for warmth. This is another snapshot of how we examine the MCP joint, PIP joints. Then we'll move on to the lower limb.
Rotation of that hip, that's as far as we have to go with that joint. Now the knees, we need to inspect and feel for any kind of swelling. Inspecting, one looks at the dimple about the knee and the suprapatellar area to see if there is any fullness, which there really is not on this knee. We'll palpate the joint space for tenderness on both sides. Is that tender? Okay, because it's not tender, I'm going to put it through its full range of motion. I'm going to flex the knee and extend the knee. Any discomfort? Okay, it's a non-tender knee. I'm now going to see if there's any fluid in there. I'll push fluid from the medial side over to the lateral side and push back. There's no fluid bulge. And finally, I will compress the suprapatellar pouch and push up from down below and see if that kneecap ballots. And it does not. This is a non-tender, non-swollen knee. Comparing the knees, this knee does not have the same amount of dimpling, and there's a slight fullness to the suprapatellar pouch. I'll palpate it for tenderness, and it is tender along the joint line, so I'm not going to put it through its range of motion. I'll put pressure on this knee to push fluid medially to laterally and back. I do not demonstrate a fluid wave. So now I'll squeeze the suprapatellar pouch to force any fluid down underneath the kneecap. Pushing from below, I'll see if I can blot that kneecap, and I can. So there is an effusion in this knee. This is a swollen and a tender knee joint. Okay, now I'm going to examine the...
So this is an important joint to examine because most of our rheumatoids will have swelling in the knee, and it's absolutely essential to make the patient lie down and examine the knee. So sitting position, if you see the knee, many knees look as it is not swollen. So when we make them lie down and examine, you can make out the swelling much better. We'll quickly move on to hip joints. Hip is a joint which is generally scored only for
The hip
tenderness.
joints are deep, so we do not palpate them for swelling. We test for tenderness. We can internally and externally rotate the hip. Does that give you any discomfort? I'll take the hip through its full range of motion and flexion. Tell me if any of this gives you any discomfort. Internal rotation, external rotation. So that is a non-tender hip. I would do the same with the other hip. Joint. The ankle joint proper, the tibiotalar joint is observed for swelling and palpated across its anterior margins. Is that tender at all? It's not tender, so I'll put it through its range of motions, which are dorsiflexion, plantar flexion, inversion, and eversion. Is there any discomfort there? No. And I don't feel any swelling within that joint. The midfoot or tarsal joints are evaluated for tenderness and swelling by squeezing with the hands and then put through their range of motion by inverting and everting the joint. And there's no tenderness or swelling there. I'm now going to demonstrate the toe joints, which are similar to the finger joints. I'm going to palpate each joint for tenderness and swelling from the sides and from the top and bottom. Is that uncomfortable at all?
Yes.
So that's tender, so I don't need to put it through its range of motion. I'm going to palpate the second one from the sides and the top and bottom. Any discomfort
Yes.
there? That's tender, so I won't move it. Palpating from the sides and the top and bottom. Any discomfort there? It's not, so I'm going to flex it down. Is that uncomfortable at all? The fourth, I'll palpate it from the side and from the top and bottom, non-tender. I put it through its range of motion. And finally, for the fifth, palpate it from the side and from the top and bottom, no tenderness. I put it through its range of motion. Similarly, with the smaller joints, palpate from the side, the top and bottom, any discomfort, put it through its range of motion. From the side, the top and bottom, no discomfort, range of motion. Side, top and bottom, flex it, no discomfort. Side, top and bottom, again flexing, no discomfort. And finally, from the side, top and bottom, and flexing and no discomfort. And there's no tenderness there either. So doing that on both sides, we've now completed the 66-68 joint count. We have recorded the objective findings of tenderness and swelling by both palpating and moving the joints through their range of motion when necessary. The exam has been carefully recorded by an assistant, and we now have the completed joint count. The 66-68 joint count is recorded on this two-page form. It's very important that every space be filled out, and it's very simple. Zeros indicate the absence of tenderness or swelling. 1 indicates the presence of tenderness or swelling. For those joints that have been replaced or fused or are otherwise inaccessible, then an NA should be recorded at that space. All the spaces should be completed, and it is very nicely set out in terms of left for tenderness and swelling, right for tenderness and swelling. It's a very straightforward form, and that's the completion of the 66-68 joint count form.
This completes, this is not projecting that well, this completes the evaluation of 66 joints for swelling and 68 joints for pain. And this can be documented in a sheet like the doctor has shown in the video. It is very easy. If you are trained, as a rheumatologist, I would be able to do this examination in 5 minutes. So it doesn't consume a lot of time because you know to do quickly, because almost invariably not all the joints are going to be tender and painful. So quickly move on. Only if you have an assistant to document, it becomes still more faster. This is one more way of documenting. You can circle or color the joints, and at the end of the day, you count or make somebody to count, and you have the tender joint and swollen joint. And there are many patterns. 66, 68 joint is what is done in clinical trials, but in routine practice, we use only 28 joints to follow the patient because it is quicker. It involves the upper limb joints, omits the temporomandibular joints, sternoclavicular joint, acromioclavicular joints, and also omits the joints in the feet. So it on a group basis, it is found to be as good as 66 joints, and it is useful to follow patients on a long term. If our patient has got predominantly lower limb arthritis, it is prudent to assess that and document as well. And with this, I'll stop here. Thank you very much for the patient listening, and pleasure of seeing the video. And if there's any question, I'm ready to answer. This is only for rheumatoid arthritis. The same joints are counted for psoriatic arthritis, and even in spondyloarthritis, particularly the peripheral arthritis, are counted and documented in the same way. The spinal joints are done in a different way, which Dr. Padmanabha Shenoy had demonstrated how we do, like a tragus to wall distance, Schober's test, and intermalleolar distance, and lateral flexion. So that is done in a different way. So all the joints, whether it is rheumatoid, lupus, spondyloarthritis, psoriatic arthritis, can be assessed in this way. This is reasonably fast. Once you are used to doing it, you can do it at the maximum of 10 minutes. You can finish the joint examination part. So if you are allotting about 15 minutes per patient, this will take about 6 to 7 minutes to finish the examination and document. Yes, sir.
As seen in the video, she doesn't do the range of movements after finding the tenderness.
Yes.
Won't the range of movements also be valuable for follow-up later on to
No.
know the value of the
Yes.
treatment?
It's a very good question. So it is very valuable in a different context. So, but for the purpose of documenting, say every visit, you know that that joint is already restricted. This is for every visit. If the joints are tender on palpation, that she is just telling that there is no need to move the joint to demonstrate pain. See, when you press the joint here, see, assume that I am examining my MCP joint. If I, no pain, if I say pain now, so this joint is already counted as tender joint. There is no need to demonstrate pain by moving through the joint. That is inflicting more pain on the patient already who is complaining of pain for the joint. It is for the documentation of painful and tender joint, there is no need to move. But by clinical examination, and we will know that that joint is not moving well, and we will try to do whatever, this joint is swollen and is not moving well, probably I might inject a joint, I might send them to physiotherapy. That is useful information, but not for every time we need not document that. This purpose, what she is telling is, the patient is already complaining of pain. Why again move and inflict more pain just to document that this joint is tender? That is what she is implying there. She is not telling that you should not look for joint range of motion. And when you routinely first time we examine, we always note which are the joint which has got restriction.